Dr. Lim Wee Kiat.
Mr. Speaker, sir, may I have a permission to take questions 17 to 21 together, please?
Yes, please.
Sir, on the 19th of November 2020, Khoo Teck Puat Hospital, KTPH, was informed by its laboratory that its immunohistochemistry test, or IHC test, for human epidermal growth factor receptor 2, HER2, were producing higher than expected rates of positive results for breast cancer patients. Preliminary investigations by the laboratory suggested that some of the HER2 results may be inaccurate. Following the incident, the Ministry of Health has been working closely with KTPH to ensure that the affected patients are provided with adequate support. KTPH has sent the samples of all patients who have been tested HER2 positive since 2012, when HER2 testing first started in KTPH, to external laboratories for retesting to determine how many have received inaccurate results. Preliminary investigations by the KTPH laboratory suggest that the inaccurate results could be due to suboptimal staining process. The KTPH laboratory has since stopped in-house testing for HER2. The Ministry of Health has also issued an alert to our other public healthcare institutions to conduct a quick review of their laboratory-developed IHC tests to ensure that positivity rates are within the acceptable range. Thus far, we have not received any reports of similar risks from other healthcare institutions. KTPH's Department of Laboratory Medicine is subject to regular inspection by MOH as part of the regulatory processes under the Private Hospitals and Medical Clinics, or PHMC Act, to ensure that its laboratory facilities, systems, and processes are in place to meet patient and personnel safety standards. In addition, the laboratory is accredited by the College of American Pathologists, CAP, where the last biennial inspections by peers were conducted in 2019. As at 23rd December 2020, 200 patients have been reclassified from HER2 positive to HER2 negative. Of these, 8 patients were treated at private hospitals and 192 patients at government hospitals. 8 patients are still pending retests. Joint care teams have been formed, comprising KTPH surgeons, histopathologists, and the treating oncologists to review the individual care plans for these affected patients based on the change in their HER2 status. KTPH and the treating oncologists are in the process of actively reaching out to these patients to conduct open disclosure and to assess these patients for any potential side effects due to unnecessary treatment. The more common side effects include diarrhea, chills, and fatigue. These are usually short-lasting. About 3 to 4% of those who underwent HER2-directed treatment, for example, using Herceptin, may also experience heart problems. KTPH is also reviewing the bills of these affected patients. The portion of the bills which arose from the unnecessary treatment will be fully refunded. KTPH is also ready to provide any clinical and financial support to the affected patients, including ongoing or follow-on treatments, if any, which may be needed as a result of this overtreatment. The National Healthcare Group has convened an independent review committee comprising external experts from multiple relevant disciplines in the healthcare industry. The objective is to conduct a thorough evaluation of the incident to understand better the lapses that have occurred and recommend appropriate measures to improve the process. This ensures that any system gaps are identified and addressed swiftly to prevent recurrence of similar incidents. The committee's investigations are ongoing right now, and more time will be required to ensure a thorough review. NHG will provide an update when more information is available, and these findings will be shared with the other healthcare institutions for improvement. Thank you, sir.
Dr. Tan Wu Meng. Mr. Speaker, I start by declaring that I'm a doctor who happens to be a specialist in medical oncology, but I should also declare that my Clementi residents who follow the news, some have also raised this issue with me in my MP capacity. Sir, a number of residents have said this unfortunate situation should not have happened, but it has, and it is incumbent upon the authorities and the hospital to do the very best to support the affected patients in as holistic a way as possible and as compassionately as possible. Sir, I have two supplementary questions for the SMS. The first is that in terms of supporting the patients, will the relevant authorities bear in mind that patients who undergo unnecessary treatment as a result of this unfortunate situation, some of these patients will have had to make recurrent visits to clinic, recurrent visits for treatment involving time off work, caregivers taking time off work, all of this with possible financial implications as well as implications for job security in the current COVID climate. And I ask, will the ministry, together with KTPH, consider this compassionately and holistically in supporting the patients who have gone through this? The second question to the minister, to the SMS, is that even as the root cause analysis is ongoing, can the ministry assure us that we will also look at whether any areas of improvement may impinge on other immunohistochemical tests that may have come out of that relevant laboratory? Sir, I say this because pathology tests, immunohistochemistry tests, they are like the charts which guide sailors at sea, which guide the treating medical team, which guide the patient. And if there has been an issue with the charts for whatever reason, it is of course a concern for navigating the patient care journey and giving the relevant treatment. Sir, I raise these questions to the SMS. Thank you.
Mr. Speaker, I thank the member, Dr. Tan, for raising these two questions that I'm sure must be on the minds of many patients and relatives who are cancer sufferers. First, I think I must say that Herceptin treatment for HER2-positive patients usually is not so much of a monotherapy, that means on the standalone. Usually it's in combination with other chemotherapy drugs for breast cancer. So in other words, even in a HER2-negative patient, where you don't need Herceptin treatment, you will still require some chemotherapy to overcome breast cancer, and therefore you will still have to come for recurrent visits, treatment, monitoring, and testing by the managing oncologist. But we know that some of these can create a lot more anxiety, maybe a few extra visits that will be required for monitoring of side effects, and KTPH and the managing oncologists and doctors will take a compassionate approach to reassure, to also help these patients to overcome their disease and their anxieties by keeping close communication with them through a more dedicated care team, especially those who are affected by the change in result status. But I must also say that in this situation, where the test is more, issue is one more of a false positive, it does mean that some patients would have perhaps overtreatment. But I think it's probably a preferred state than to have undertreatment, especially when you have cancer. In this situation, HER2 testing has shown that some of them should have been classified as HER2 negative, meaning that actually the patient do have a better prognosis compared to those who are HER2 positive. So I think on the overall thing, it is not necessarily a bad thing for the patients to have actually reclassified as HER2 negative on testing. KTPH has informed that any cause and as well as investigations that are done as a result of HER2 treatment, Herceptin treatment, will be borne by the hospital and refunds will be given. So I think that will go in some way to relieve some of the financial pressure and stresses that the patient has undergone. On the second question of whether the other immunohistochemistry tests would be reviewed, I think we must understand that immunohistochemistry testing is classified in most laboratories as a highly complex test. By highly complex, what I mean is that it is a test that is not so quite the same as you drawing a blood test, pop it into a machine, and the result comes out within a few minutes. It's not as simple as that. It's a multi-step process that has multiple steps of human intervention in the process. First, as a tumor specimen is removed, what we call a cold ischemic time. How soon that tumor, after it's removed from the body, gets put into a fixation. That means to fix the tissue in the chemical. Usually it's recommended to be less than 1 hour. So how the operating team in the operating theater, not even the pathologist, just how the operating team handles the tissue, when do they take the specimen out, when do they call for the team to put into the solution, you must also put into the correct solution. Otherwise, if you put in the wrong chemical to fix the tumor tissue, that sample cannot be used for IHC staining. Then when it goes to the laboratory, how thick the specimen is sliced, what kind of stains are used, what kind of temperature that it's done, what is the concentration of the stains being used, what is the choice of antibody, and subsequently after staining, how the pathologists themselves grade the degree of staining. And the degree of grading of staining is what we call a semi-quantitative method. It means it is not a plus or minus, yes or no. It is a gradation of degrees of staining. Just like when you look at your iPhone photos and you try to adjust the contrast. Between two sets of persons looking at the adjustment, to you this may look pleasing enough, dark enough, to another person this may be too light. So there's some degree of inter-observer variation, which a trained pathologist must then make the judgment call and say, is this dark enough stain to be deemed as a positive, 3+, 2+, 1+, or 0? So it is semi-quantitative in that sense. Therefore, you can appreciate that this being a very complex test, as in most other immunohistochemistry tests, will require multiple levels of validation. But I will also say that the reason why this issue was discovered is because the institutional processes within KTPH has allowed this to be picked up. Because being a multi-step process, if we depend on one single process, one single point to validate its accuracy, then it will be a very, very high risk of failure at some point in time. But fortunately, because there is an institutional process through the tumor board, a multidisciplinary review board looking at tumor outcomes, specimen, and treatment, it was flagged up at the point of review that the positivity rate seems to be higher than expected, and that's what triggered the review. So I would say that the processes are there. We now need to look at which part of this process could have been strengthened further, and that is the ongoing review that the expertise team is looking at the moment. So we will also use this chance to learn about some of the failures that may have happened in this multi-step process and help the laboratory to strengthen them for other immunohistochemistry tests as well.
Ms. Cheryl Chan.
Thank you, Mr. Speaker. I would like to ask SMS because my original questions were not being answered. Actually, the main thing around it is this, right? Because as SMS has said, all these patients has gone for recurrent visits to their respective doctors. Certainly, over the entire period of time, something must have been picked up, even if the first diagnosis was supposed to be wrong. So as you said, with all the specimens and also all the different processes that's in place, why wasn't there an earlier trigger? I think that is the key to the issue.
So I thank the member for asking this question. It's going to be a little bit technical, but let me attempt to explain this in a way that most people can understand. Now, inherent in any laboratory test, there's always a chance of false positivity, false negativity. That relates to the sensitivity and specificity of the test. In recent months, because of COVID, we've all been doing PCR testing. Everybody is a little bit more attuned to the concept of why a certain test can give you a false positive and false negative. Immunohistochemistry test actually is fairly notorious for having this kind of risk because, as I said, it is semi-quantitative. So the staining process is like mixing poster colors. If any part of the mixing process, the process of processing the specimen by putting stains, dyes, and counter stains, is not done optimally, the keyword here is optimal. Right? You can perform all the steps, but if the timing is a bit off, maybe the concentration is off by a little bit, the kind of picture that comes out on the slide that a pathologist gets to look at will be quite different in terms of contrast and staining. If I may quote from a paper in Journal of Clinical Oncology, published in 2015 in British Medical Journal, it gives a background that early studies using this technique to look at HER2 staining has shown high false positivity rate as high as 19%, in the early days when this test was started. Over the years, after 2007, when a stronger push by the professionals to push out guidelines, that false positivity rate is now dropped to about 6% or less. But it's still present. It's never going to be zero. And what we need to do in this instance, when the clinical practice within the institution of regular review of data accumulated over time, because to show that there is now an over-representation over time, you need to have accumulate enough caseload over a period of time to show on a retrospective basis that after 3 years, 5 years, I accumulated 200 patients, 1,000 patients, and I aggregate the data, and I realize, oops, it is actually more than 6%. Then this is where it triggers a review. But when you first start the test, you only have 1 case, 2 cases, 3 cases. There's not enough to do statistical analysis to tell you whether you are above or below the 6% mark. So I hope that gives a sense that it's not a complete failure of the system. It is inherent in the test, and that is how a review process through a multidisciplinary tumor board picks up any outlier conclusions to trigger a review.
Ms. Hazel Phua.
I thank the SMS for his reply. I have a few supplementary questions. Firstly, while these errors were actually discovered in a review process, since the error actually started in 2012, why did it take so long to discover the errors? Is it a standard time frame for enough statistics to be to flag out a possible error? And secondly, would the ministry consider a second independent test for serious illnesses? Last supplementary question is about compensation to the victims. What sort of compensation is being considered, and is a lifetime of free healthcare on the cards? Thank you.
So let me clarify the member's misconception. When I say in my reply that KTPH is reviewing all the results from 2012, 2012 was taken at a point in which the test first started in KTPH. It does not mean that all the results going back to 2012 are erroneous. So in that sense, KTPH is being prudent and careful by going back, super kiasu, going back all the way to when the test first started. It may well be that the errors could have occurred in the last 3 months or 6 months. I think the key point usually is when the reagent has been changed, a different brand of reagent, or a different provider of the reagent could usually be the starting point of why the protocol or the test conditions were no longer as optimal as it should be. But going back to 2012 when the test first started was really trying to be comprehensive and to be careful to make sure that we don't miss anybody in the process. It doesn't mean that the test was erroneous from 2012. So the results of the review are still ongoing, so I do not want to prejudge the review process from the experts. Let's wait for the experts to look at all the results going back to 2012 and then decide at which point, what step of the process that could have been where the error occurred. Now, when it comes to the question of whether you're going to get compensation, I think, as I said earlier, any treatment cost due to the treatment arising from a positive HER2 results, in other words, usually treatment with Herceptin as the drug, the cost of the drug likely will be refunded. Any investigation or tests or treatment of any related complications as a result of, say, Herceptin would also be refunded as well. But to then say that this translates to a lifetime of compensation, I think that would be a little bit too far thing to stretch, because most of the complications, if any, or most of the side effects relating to the treatment are transient. Diarrhea, a bit of fever, a bit of chills. They do not have long-term consequences, they are not long-lasting, and I think we have to take that in the correct context of medical treatment. I hope that answers the members' questions.
Ms. Hazel Phua.
I also have a question about a second independent test for serious illnesses.
I take that as a general question, which in any form of medical diagnostics, if the clinician is unsure that a particular test alone cannot give you a high degree of probability of predicting a positive diagnosis or presence of an illness, then it behoves clinical judgment to call for a second test. But immunohistochemistry is a specific, unique test. It does not necessarily mean that an alternative is available, although in the literature, there are other alternative tests that could be done, but we have to consider that against the time needed to do it, because that could delay treatment, and also whether that brings on unnecessary costs. So that, I think we should leave it to the experts to come up with a process guidelines on what is a testing algorithm to decide for Herceptin-related treatment.
Dr. Lim Wee Kiak.
Thank you, Mr. Speaker. I think the SMS also have not fully answered my SQ also, my PQ, regarding actually how many patients were actually involved and how many patients has actually MOH engaged in the first place currently now that's affected by this particular error. Currently, what measures has been taken to ensure the well-being of the patients, both psychologically as well as physical health? And also, I'd like to know, what was the average cost of the medication of this particular medicine you just mentioned? Because I think you didn't mention anything about the cost. You just mentioned that you'll be refunded, but I'm not sure what is the actual cost. And I do have a patient who is my resident in Sembawang JRC who saw me at my people session. She was very worried when she saw the news. She said she's one of them. And when I asked her whether has MOH contacted her, she said not yet. So she was asking me for legal help now, how can she self-sort. So I would like to ask the SMS now, what avenues does affected patients have now to seek compensation for such an error? Thank you.
So I think the anxieties of patients are quite understandable, especially when they read about this in the news. I would want to give assurance and say that if you have not been contacted by your oncologist, it means you're okay. Because those who are affected, as I said in my reply, 200 patients so far have been reclassified from HER2 positive to HER2 negative. In other words, these 200 patients from a poor prognosis tumor now has a better prognosis tumor. Because HER2 positivity codes for a poorer prognosis to begin with. And therefore, it needs the managing oncologist to go on a one-to-one with any of these patients whose status have been reclassified to do a detailed conversation on their own clinical prognosis, what is the stage of the tumor, what treatment has already been given in the past, what will be the ongoing treatment needed. And not all patients, I must say, who has been tested HER2 positive on any, well, be it now or previously, will go on to Herceptin treatment because it is a treatment decision that is guided by the needs of the patient, not just by the test alone. There are some patients for which the body may be too frail. Even if you're HER2 positive, you may not receive Herceptin treatment. On the other hand, there are recurrent tumors where the oncologist feels that you have reached end of line, you will still require Herceptin treatment as a last resort, even though it may not be the first line in some other cases. So I think that the decision matrix is not a straightforward one. And for patients who may be affected, it's best to seek your oncologist's advice. But if you have not been contacted specifically for this, it means that you are okay. Your status remains as it was from the last conversation with your oncologist. The cost will vary from institution to institution. I do not have the exact numbers right now, because it also depends on how many doses, how long the duration of treatment each patient is, and also different body size of patients may require different dosages to begin with. So I think that is something that we cannot generalize. It's probably quite individual. That is why the dedicated care team from KTPH, especially the oncologists, will have to reach out to affected patients one by one and go through the conversation in a detailed manner.
Ms. Joan Pereira.
Thank you, Speaker. Thank you, SMS, for your reply. In addition to the physical side effects that many of these patients might have suffered, some of them might suffer panic attacks, anxiety attacks. So would Khoo Teck Puat Hospital be able to support medical costs relating to mental health? Thank you.
So I think it's best we leave such assessment and decision to the managing joint care team together with the patient. because a panic attack or anxiety episode can occur with or without cancer, can occur with or without treatment. There can be myriad factors involved. But the joint care team will deal with the patients with compassion and find a way to help them overcome this current hurdle they are facing.